Welcome back to another week of the RevMD podcast. This week, we're going to talk all about billing an E&M code with an annual or preventative code, so you can really kind of wrap your head around when is it appropriate to add that E&M with a 25 modifier, when should you just stick with the annual or preventative code, and how do you truly operationalize this within your practice so you don't have patients calling who are upset and trying to figure out why they have extra charges on their bill or extra copays or deductibles that they were not expecting. Now, as you guys know, my name is Heather. We have a full service medical billing and coding company called National Revenue Consulting. You can head over and check us out on our website, www.nationalrevenueconsulting.com, or shoot us an email at info@nationalrevenueconsulting.com. We also have a Facebook group called RevMD, so head on over there if you are looking for extra tips. And really, we're just at a point where we're excited to be educating physicians. I don't think we get enough of this in medical school and any other kind of healthcare training. And so that is our job, is to help educate and get those engaged and learning tips that we all need to know so that our practice and the revenue grows as it should. So if you're new to the RevMD podcast, please feel free to share us with other individuals. As always, our advice is for educational purposes only. And if you have specific questions, make sure you get those over to your billing, compliance, or legal team members, depending on the question. Now, all right, let's get to the topic. Whether you are family practice, internal med, or even OBGYN, it is common to have a routine preventative visit where a medical issue or problem may come up. And so, for example, you're finishing an annual wellness visit, and just as you're finishing up, the patient says, wait a minute, I have this rash, I have this lump, can you take a look at it? And obviously, if the issue is minor and you don't really evaluate it, then probably not going to qualify for an additional E&M code. However, if you do spend time doing a true evaluation and management where you're looking at something, you're ordering a test or prescribing, a medication, then that starts to get out of the scope for a wellness visit. And so, of course, as long as that is medically necessary, separately identifiable, and significant, then you can charge for that. Now, some of you may know that I pretty much just rattled off the definition of the modifier 25, and it's really the use and the definition of that modifier 25 on an E&M code that allows you to bill that alongside a wellness visit, again, when it's medically necessary, it's separately identifiable, and it's significant. So from a coding perspective, there is a very bright line between a preventative visit and a problem-oriented visit. And of course, one is going to be for promoting health and wellness, and then the other is going to be there to treat some sort of acute or chronic medical problem. And so we often hear several different questions that we'll go through today. So from our clients, one of them is, when can we bill for both of these visits? What is the difference between that preventative visit and when I can bill for that problem-focused visit? And how do you make sure you're not double counting time if you're using that to bill for a visit? And we'll talk about why it may not be the right thing to do to use time at all in those scenarios. And then how do you make sure your patients have a heads up, because they may end up with a higher out-of-pocket than they expect? So the good news is I do think with the 2021 E&M coding changes, it does make it easier to kind of draw some lines between these. So first, I'll kind of share, what is a preventative visit, right? So preventative visits, those CPT codes between 99381, 99397 are for typically those patients covered by a commercial insurance or Medicaid or some Medicare Advantage plans. And of course, patients love to see these visits because they're oftentimes not subject to a copay or deductible, and they're typically covered once per year. And these are your comprehensive preventative medicine evaluation and management services, which depends on the age and the gender, depending on, what those individuals will receive. Now, there are different codes for Medicare patients, and I'm not going to go over those in great detail. But really, the preventative visit is really to continue the health and wellness of that patient. Now, new coding guidelines also state that if a new or existing problem is assessed and managed at the time of those preventative visits, the physician should bill for those. But if it's an insignificant problem that does not require extra work, then it should not be billed for a visit. So if a patient comes in for a preventative visit and the clinician also looks at that rash that we talked about and notices that the blood pressure is elevated, of course, these observations alone are not going to be enough to bill for it. However, if you take a look at the rash, or if you do something with the blood pressure and you order additional tests or you prescribe a medication, then there is some level of medical decision-making that has occurred, such as prescribing a topical treatment or prescribing something for the high blood pressure. And so that in and of itself is going to qualify for an E&M visit, such as something between a 99202 and a 99215 that will be billed alongside that preventative visit with a modifier 25. Now, if you're thinking about this and going, well, how do I really know if it's one visit or the other? We can go over some examples of that. So, for example, say you have a patient, they're good health, they have really no chronic issues, maybe some stable chronic illnesses that really aren't addressed during this wellness visit. And the patient, pretty much needs maybe some prescription refills. Maybe the chronic illnesses are listed, but we're not really going into great detail about those. And the exam findings are normal. You really don't change any treatment. You don't, maybe you do some scheduled screenings, you refill some prescriptions, but nothing else really is addressed. Then that's really going to be the scenario where you're really only going to be billing a preventative or wellness code. Now, however, say the patient comes in, they have a rash, or say they have a lump on their breast, and you evaluate it. You order some, additional diagnostic testing, you discuss, findings, potentially create a treatment plan for any sort of, acute, uncomplicated visit or an active, stable problem, then that is going to qualify for an E&M code. And I'll just caution that in general, you're going to want to be careful that you don't use time to code that E&M code. And the reason is, say you spend 40 minutes with a patient, but 35 minutes is with regards to the annual visit, you can't count that time again for the E&M visit. So you can't double dip, for example. So it's important to recognize that if you are going to bill for an E&M, if you have evaluated and managed something, you, one, have to document it, right? We all know if it's not documented, it's not done. And two, you're going to want to use the NDM in order to classify which E&M code you should use. So I would highly recommend not using time in those scenarios. Now, like I said, Medicare is a little different in terms of the codes and how they manage their preventative visits or their wellness visits. And so I'm not going to go into detail. I've talked about those in the past, but just recognize that those requirements are slightly different. But in general, they require the same type of information, right? You're collecting and updating medical information, you're getting family and social history, et cetera. And the same situation occurs that if you're in one of those wellness exams, or preventative exams is a better term for it, those preventative physical examinations, again, that's those G0402, G0438, G0439, depending on if this is a welcome visit, an initial or subsequent annual wellness visit. The same scenario can occur, right? They're in there and then they come up with a problem, issue that you're then having to evaluate and manage. And the key is really, is it medically necessary? Is it significant, right? Is it truly requiring medical intervention? And is it separately identifiable from, say, the wellness visit or what you're doing? So that's just really, really important. Now, when it comes to selecting the level or service for the E&M, right, performing a problem-oriented E&M service on the same date of service as this wellness or preventative visit adds a layer of complexity when you are trying to choose this. But I do think, like I said, it's a little bit easier now with the 2021 E&M rules, because when you're selecting a code using the new E&M guidelines, you basically are able to use those MDM tables to be able to classify whether or not this is a level 2 or a level 5. And it's not really all about this whole history and exam piece. That's not really what's being used to select the level of service. So this does make it a little bit easier. Again, I do caution using time just because you have to make sure you're only counting the time managing the problem, not the entire time managing the preventative or wellness visit. And so you do have to, if you are going to use time, really be careful that you've documented exactly how much time you've then spent on just the E&M portion, and you'll want to document that extremely well. So we can talk about a few examples, but hopefully this is starting to become a little bit more clear. So here's an example. We have a 50-year-old male. They're, an established patient in the office. They have a history of diabetes, maybe hyperlipidemia, and they're coming in for a wellness visit. And all the required components of the wellness visit are, done and completed. But then the patient asks for a refill of his diabetes medication. The physician asks the patient if he's taking his medication and, of course, following the recommendations from a diet and exercise perspective. And the physician also performs a focused physical exam, discusses medication management for the diabetes and hyperlipidemia, and then orders some maintenance lab. Obviously, the physician is going to be documenting any of these problems. They bill for the annual wellness visit, and then they add a 99214 because they addressed 2 stable chronic illnesses and then also performed prescription drug management. So then adding the 25 modifier on the 99214 plus the wellness code visit is appropriate. Now, this is a good example where, again, you're following that MDM table, talking about the 2 illnesses, the chronic illnesses that you're managing, and then you're actually prescribing medication. Now, what happens if, say, a similar patient had come in and they have chronic illnesses, and say you do evaluate and manage them, but you don't put anything in the chart? So say the patient has, abdominal pain, and while you do evaluation and management, you don't put any of that in the chart. Say you just put abdominal pain in the ICD-10s, but you don't actually have a section where you say what you evaluated and what you managed and truly what you did. What happens then? Well, it's just like, we all know, right? If you didn't document it, it's not been done. And so you can, you may get paid for it, right? Because you guys all know, just because we submit something in and they pay for it doesn't mean we've coded it correctly. Sometimes you'll get a flag where they'll say, I need more information, or I need you to submit the medical records. And then if it's paid for, you can probably trust that that's probably accurate. Not always, but in general. But if they ask for medical records and say you didn't document the E&M or any information on the problem-focused visit, they're going to deny the E&M code. They're going to say it's not medically necessary because you didn't document it. So again, this really comes down to documentation. I can't say that enough. So let's do another one. So say you have a 30-some-year-old female. This is a new patient coming in for a preventative medicine visit, which was required by her employer. The physician completes all the requirements for the preventative visit, and then during the history portion, they tell you that she's got some knee pain, which is exacerbated by running. The physician then obtains a history about the pain, examines the knee, goes over reduction of activity in order for the pain to subside, maybe even gives a handout on some knee exercises, and then suggests recommending a knee brace and following up if the pain does not decrease. The physician documents this extra work because that's right, super important, and then bills the 99385 for the preventative visit, since that's, the 18 to 39 year range, and also drops a 99203 because they addressed one acute uncomplicated injury, and that is added with the 25 modifier. So again, you're seeing how I'm using the MDM coding system along with that preventative visit. The knee pain has been addressed, it's been evaluated, it's been managed, you documented it. That would be totally appropriate. So hopefully those 2 examples are helpful in kind of just wrapping your head around this. Again, we get lots of questions about this, and I would say modifier 25s in general, have gotten a lot of flack in the past, and I think sometimes they're overused, and I think sometimes they're underused. So this is all about just finding that sweet spot. All right, workflow tips. I cannot tell you how many patients call our customer service line for client offices because they are upset with the additional fee that they're getting. And it's hilarious because some of the patients call and they're like, I did not talk about any problem-focused problem. This was just an annual visit. I had talked about nothing else. And then you go and read the chart, and I've read the charts, and they will say clearly the ailment that was found, what was discussed and evaluated, and it's a completely appropriate E&M code. And it was, sent in, approved by the insurance, paid, but the patient may receive a different copay or deductible because it's not that preventative visit. And so patients call back and they're very, very angry. And so some things that I really highly suggest if you're an office who does bill these E&Ms along with preventative visits is that you make sure that a couple things. So number one is when staff are talking with patients or they're scheduling appointments, it's nice to remind them, hey, this is an annual preventative, but if there are any problems or issues that are addressed, that may result in additional charge, based on the fact that something else has to be addressed, and kind of really clear the lines that there are annual preventative visits, and that if anything or larger issue comes up and is managed, that then qualifies as a problem-focused exam. The other thing you can do is actually have documentation with the patients that they sign that actually clearly states, here's what an annual and preventative visit is, here's the what it covers, and the discussion regarding, what you kind of cover in those visits. And then if any issue or problem is brought up that then we evaluate and treat, that's going to be a separate charge. Now, of course, you could always tell the patient, hey, this is an issue, and we're going to have you come back and have another appointment. But we all know that that's not what they want. It's not what you want. It's just harder to manage all of that. So just making sure that they truly understand, either at scheduling or while they're in the waiting room, or a form that they sign, or a poster on the wall in the exam room, whatever it is. Just something, so you're trying to get that education across to them. Maybe even something that they sign. I'm a big proponent of education and signing. Or we were actually brainstorming the idea about making like education videos on your website for patients on these types of things. And this would be a good one to cover, right? So we could have patient educational things on copays and deductibles and out-of-pocket maxes and all of that. But then you could also have one on well versus sick visits. So there's lots of ways you can educate and talk to your patients. Find one that works for your office, brainstorm with your office staff, figure out which workflow may work best. But having something is really critical. Is it going to stop all the patients from calling? No, it's really not. Sometimes they have questions and they're going to call and they're going to complain. But again, all you can do is try your best to educate where you can. And again, we all know the medical system's confusing for us, right? We even went to medical school. So it's even more confusing for patients and for their families. So please remember, if you do have a problem-focused issue come up and you do have medical decision making that you've documented and that you've done, it is appropriate to bill for it. Just got to document it and got to make sure that you're using the right level of coding, which again, now is much easier with the MDM coding than it is with the prior coding system. So hopefully this helps kind of clear this up. Again, we've had a lot of questions on this over the last few weeks, so thought it would be best to do a podcast. As always, if you are looking for a full service medical billing and coding company, we are happy to help. We are looking forward to the end of summer, kids getting back to school. And so I hope you guys have enjoyed your summers as well. And as always, if you do have questions, shoot them over to info@nationalrevenueconsulting.com. Have a great week.